Thank you very much, distinguished panel, ladies and gentlemen, for the opportunity to talk to a crowd of surgeons, very distinguished surgeons, including my colleague and my old friend, Thor, on IRAD. And the story of IRAD, I think, needs to be spent a few moments on, because it tells you that not only surgeons, but also cardiologists are interested in this particular area that ends up often in the hands of surgeons, but not always. Let me fast forward, actually, to this little sketch or statistic from Japan. As you all know, the Japanese society is ahead of us in terms of aging and development, and they see already in the next couple of years to come an exponential growth of patients succumbing to acute and chronic aortic conditions as well as valvular conditions, and certainly no increase in coronary artery disease and other diseases that we are basically controlling fairly well. So there is an increasing demand in the years to come to focus on aortic condition, no matter what dissection, aneurysm, all sorts of other things as well. And back in 1996, let's fast backward now, it was basically, where's my pointer? Eric Isselbacher, whom you see here, at a younger age, of course, myself, we got together on a parking lot in New Orleans after the AHA meeting and discussed our mutual interest in aortic dissection, but didn't find any data to glean some insight from. There wasn't basically published anything about that. And we basically had the idea to call in Kim Eagle, who is a very organized person at times, I should say, but with a lot of expertise in database management. And we got together, the three of us, to create a registry because we couldn't answer important questions such as what to do with a patient who's suffering from a type B dissection and got pregnant. Or is it okay to allow somebody to go hunting after aortic dissection, repaired or not repaired, or A or B? And the ideas to answer these questions basically led to so-called call groups, or whatever you call it today. I mean, some mutual interaction with these people. Linda Pape from Boston, Toru Suzuki at the time from Tokyo, some other guys from Italy, Enrico Bossone, Kim again. We got together at a younger age, of course, 20 years back in time almost, and discussed these questions, simple clinical questions, by email exchange. Email came up at the time. But with our friends that we motivated to participate in the registry all over the globe, we were able to publish a few years later, 4 years later actually, the first manuscript that originated from the first 4 to 5 years, 4 years I should say, on new insights into an old condition or old disease such as dissection in JAMA. And that triggered a lot of response from all over the world, and more hospitals and more groups got interested in joining us and collecting data on type A and type B dissection. International Registry stands for Registry of Acute Aortic Dissection. And we're basically collecting from various sites over the globes and started to produce manuscripts such as predicting death in type A, all sorts of other frontier discoveries with an increasing amount of patients collected in this registry. I don't have the time and the motivation to discuss all of this. A total of 125 publications so far, and the next 15 minutes only allow me to pinpoint a few of them. It just shows you that various issues, important questions such as the size of the aorta before it dissects, the predominant failure rate in women, and all sorts of things could be answered with an increasing number of patients collected over the years. So as you can see here, the number of cases and the number of sites grew from the initial database from 1996. And to date, we are looking at data from more than 8,000 patients with dissection, of which close to 3,000 are type B and more than 5,000 are type A dissection. It's a lot of data to be managed and to be mined. And actually, with a need of focusing among the various areas within dissection, we branched out into 4 groups, one focusing on imaging, another one on intervention and surgery, a third one on family education, and finally one on genetic underpinnings and genetic interaction. I just want to mention this group, which is probably the most active one right now, founded in 2010, led by Santi Timaki, a vascular surgeon, and Himanshu Patel from Ann Arbor, a cardiac surgeon, to document vital clinical data on patients that undergo surgery, stenting, or a combination of both in a hybrid environment. Just gives you an idea how many parameters needed to be collected to create a database from which all sorts of questions could be answered, on retrospect, of course. One important piece of data emerged on a very close collaboration with a medical statistician who found a formula to input very simple clinically obtained data into a prediction model that is very close to reality, as you can see. This prediction model for survival of patients presenting in the hospital and turning out to be type A dissection has been used by the International Guideline Committee in Europe, at least, and had been incorporated into the guidelines. I don't go through the details. It's just worthwhile reading. Very simple 4-point score to predict the upcoming mortality if you don't act properly and send the patient to surgical attention right away. Another very important finding in that analysis of basically all data so far at the time, 2007, was that aortas we believed to dissect at a certain threshold width of 5 or 5.5 centimeter. But the fact is different. The facts are that 59% of patients dissected at an aorta at a lower diameter, basically a diameter considered to be either normal or in the upper limits of normal or slightly around 4 centimeters. So the majority of type A's actually had a almost normally appearing ascending aorta, not necessarily a wide ascending aorta as we can still read in textbooks. Another very simple and obvious finding is that if somebody presents with a abnormal ECG, abnormal is very simple, either ST depression or elevation or hidden signs of infarction, abnormal ECG identifies worse prognosis in patients with type A dissection, obviously because compromising either coronary ostia or with pericardial effusion already impacting on the flow to the subendocardium. So this is an important early sign to look at and to consult, for instance, a cardiologist or an ER doctor to find out whether this EKG is normal or not normal. Very, very basic and simple. Another very basic presentational finding is the pressure at the time of presentation in the ER or on first medical contact. If the pressure is low, 80 or below 80, the outcome, no matter whether we're dealing with type A or with type B dissection, will be worse than if the patient presents in stable or hypertensive hemodynamic conditions. So very, very simple input data from first presentation. This is another interesting histogram that shows you the delay or the time needed for a patient to present in a center of excellence that doesn't need any transportation as compared to patients presented in hospitals that require transportation to centers of excellence to take care of the aortic dissection. It shows you that the time span is usually a little bit wider, or there's more patients that need more time if they need transportation. That's obvious. But we know, and this is not published yet, and I'll tell you a secret about it, the outcome of both groups was not different because of self-selection, I personally presume, self-selection of patients that needed transportation and ended up arriving in a center of tertiary care or quaternary care in a more stable hemodynamic condition that pre-selected those that died in the time waiting for transportation or on transportation. Another interesting finding, although quite obvious, at least in the first time of follow-up, is the distinction between the mortality in DeBakey type 2 and DeBakey type 1, type A dissection, I should say, or proximal dissection. Initially, there's a little bit of a difference, but on long term, and we're looking here at long-term data, 4 or 5 years, the outcome between those two groups of proximal dissection is similar, with a late catch-up of the early advantage of a DeBakey type 2, which needs probably a limited operation as compared to a more extensive operation in some patients of this category. But finally, after 4 to 5 years, the outcome is quite the same. This graph in a different presentation has already been shown in a previous talk this afternoon. It just summarizes the recent trends in the management of type A dissection as observed in the worldwide registry. And what you can take home from this upper graph here is there is, over the years, starting in the late 1990s to the present, fewer rejections of patients or fewer rejections for patients with type A dissection for open surgery in blue. There's only a small fraction of 9 or 10% that cannot be operated, but it used to be 20 or more. Similarly, there is a trend to better outcome from 30 to 25, basically 21% mortality in the same group of patients over the years, despite the fact that more were accepted and less were rejected. Similarly, in the scenario of the distal dissection, type B dissection, there is a declining acceptance for surgery, open surgery, of course, no wonder, because of the increasing use of endovascular intervention in that setting. And the better outcome in proximal dissection is probably due to the fact that we could observe an increased use of valve-sparing operations over the years. More than 1/4, probably now a third of patients undergo valve-sparing interventions. And the cerebral perfusion strategies have also shifted from retrograde to antegrade over the years, and probably with a better outcome. And this cannot be really proven in a cause relationship, but it is a temporal coincidence and most likely caused by that. The survival pattern of type A and type B in IRAD is summarized here. Type A, surprisingly, there is a group of patients that survive despite the fact that they couldn't be operated or were rejected from surgery, or at least over up to 60 days. And in type B, it emerged over the years that endovascular, in addition to medical management, obviously stabilizes the aorta and leads to a plateauing phase over the next 12 to 24 months. Again, IRAD had a particular focus, not only because of my interest, but others as well, on type B dissection. They identified a lower risk group from a higher risk group. The higher risk group is characterized by presentation in shock, small perfusion issues, hypotension, of course, and the other parameters that I discussed a minute ago basically support that. These patients need immediate attention. They cannot wait a week or a couple of days because they have already evidence of malperfusion and predictors of high mortality, and they need to be subjected to endovascular procedures that help reestablish flow and also initiate remodeling over long term and phimosis of the false lumen that stabilizes the aorta, but we don't have to spend too much time on it. Another interesting observation, very simple clinical observation, is the observation of refractory pain and hypertension in patients medically managed for type B dissection. If you identify a patient who, again, presents after a couple of days with refractory pain, it is difficult to manage in that regard, or cannot be well controlled, then you select these particular subgroups of type B dissection for endovascular treatment. And I think Thor has already shown this graph, the observational evidence of partial false lumen thrombosis, which means that only a segment or part of the false lumen shows thrombosis, but not the entire false lumen, of course, identifies patient at a higher risk for late complications, because this is triggering a metabolic activity that is basically setting up the outer wall of the aorta for rupture. So these patients are at higher risk than others that show either complete thrombosis of the false lumen or free flow with no thrombosis due to the distal exit or re-entry communications that allow the pressure to release, the diastolic pressure to be lower. The data, again, in IRAD, compiled over, I think, 15 years and published in 2015, show an edge for endovascular over medical management alone in those selected groups of patients. You may call them complicated or high risk or whatever, but obviously these patients can be identified and will benefit from an intervention in addition to medical management. This observation has been supported by a randomized trial, by another observational trial in China, and most recently from the life insurance or health insurance data in California that showed exactly the same trend with a stable course with additional endovascular treatment as compared to natural history. Again, these observations were used in the US and the EC guidelines. I just present the EC guidelines here with an indication for both endovascular treatment in complicated as well as less complicated or uncomplicated type B dissection. This is one of the latest publications. I think this is the latest from IRAD that I remember from earlier this year and early February. It showed and focused a little bit on a very controversial area in the arch, an entry tear in the arch with retrograde dissection to the ascending or distal dissection. How should we manage it? How is it managed in the contemporary area? And as you can see here, most patients undergoing surgery, open surgery for this particular scenario, and most patients with this scenario undergo either medical management or endovascular strategy. The outcome is not analyzed yet because this is just observation of what we are doing with these patients. Obviously, this is a setting similar to a classic type A with an entry tear here, and this is more close to a distal type B and may probably prompt some creative solutions and personalized management with various options of surgery, bypass in combination with stents. The key lessons basically can be gleaned from this slide. I just don't want to reiterate everything. There is simple clinical observation that can be used to predict mortality. There is surgical strategies that probably have improved over the last 20 years with additional antegrade perfusion, with other clamping techniques, with shorter delays. And there's, of course, a lot of other impact from diagnostic analysis of D-dimers, which can be a very important additional piece of information in addition to ECG and presentation in the hospital upon arrival. So very simple, basic observational evidence. So in order to summarize what I said, I can't actually summarize everything because it's a lot and only a fraction has been shown. But the idea of IRAD and the advantages that I can actually subscribe to, that it is providing insight into a very low incidence but very high impact acute clinical condition, aortic dissection, and many of us won't see so many of these, and a valuable platform for modern strategic planning and teaching as well. It serves also as a scientific scope, as a hypothesis-generating source of new information of an old disease, and has already triggered a couple of randomized studies to support the observational evidence gleaned from IRAD. Thank you very much for your attention.